Yes, sir, it's visible. And you can put in a projection mode.
Isn't it full view now?
No, sir, it's not. Now it is.
So good afternoon, everybody. We'll be discussing today about bone marrow failure syndromes, which are classified under IUIS classification. And also we'll discuss a little bit about phenocopies of inborn errors of metabolism. Although inborn error of immunity. Although bone marrow failure syndromes are under the domain of hematologists, but there are some bone marrow failure syndromes which come under classification of IUIS. We'll be discussing about them. So coming on to bone marrow failure syndrome, they comprise of a group of disorders of hematopoietic stem cells, which are due to resulting in suppression of one or more of erythroid, myeloid, and megakaryocytic cell lines. The condition may be either inherited or acquired. Etiopathogenesis, the hematopoietic stem cells may be deficient for one of the components of stem cells due to either acquired injury from viruses, toxins, or chemicals, abnormal marrow microenvironment, or immunologic suppression of hematopoiesis, which can be mediated by either antibodies or cytotoxic T cells. Or they can also be mutations in the genes which control hematopoiesis. This is classified under inherited bone marrow failure syndromes. So as we studied earlier, bone marrow failure syndromes can be either inherited or acquired. Under inherited classification, there are Fanconi anemia, dyskeratosis congenita, and other syndromes like Dykman-Blackford anemia, Schwammen-Diamond syndrome, congenital A megakaryocytic thrombocytopenia, thrombocytopenia absent radii syndrome, or Sware congenital neutropenia. The first two, Fanconi anemia and dyskeratosis congenita, under IUIS classification. The others are under the domain of hematologists. Acquired bone marrow failure can be either due to medications which are cytotoxic or other chemotherapeutic chemicals. It can also be due to toxins or some viral infections like EBV, CMV, parvovirus. PNH, paroxysmal nocturnal hemoglobinuria, is also an acquired condition which can cause bone marrow failure. Or it can be immune mediated, classified under idiopathic category. So coming on to human inborn errors of immunity 2022 update on classification of these illnesses. Bone marrow failure syndromes are classified under table 9 of this classification. So there are, first is about Fanconi's anemia. Fanconi anemia is further classified under different subtypes come from A to W. Or next, Mirage syndrome, which is myelodysplasia infection. R stands for restriction of growth, A stands for adrenal hypoplasia, G stands for genital phenotypes and enteropathy. Ataxia pancytopenia is also classified in this category. Then comes the dyskeratosis congenita syndrome. Dyskeratosis congenita syndromes is further classified into different subtypes. Bone marrow failure syndrome type 1, type 2, type 5. These are also classified in this category. There is a syndrome called as Coats plus syndrome and another named by MECOM deficiency. These all syndromes are classified under this category, table 9 of IUIS classification. So what are the clinical features which suggest a possible inherited bone marrow failure syndrome? First, it can be chronic or lifelong cytopenias. If myelodysplastic syndrome occurs in a pediatric or young adult patient, then we should be aware of this inherited bone marrow failure syndrome. Characteristic cytogenetic abnormalities are found in bone marrow, either deletion or involving chromosome ARM7. Congenital malformations are present, which can be radial or thumb anomalies, genitourinary abnormalities, or cerebral atrophy. Unusual short stature or dysmorphic findings. Some mucocutaneous abnormalities like cafe-au-lait spots, oral leukoplakia, nail dystrophy, or skin hypopigmentation. These are seen in dyskeratosis congenita or Fanconi's anemia. Some characteristic comorbidities like pulmonary fibrosis, endocrinopathies, PCOD or premature ovarian failure, lymphedema, cerebellar dysfunction, adrenal insufficiencies. Unexplained immunodeficiencies, monocytopenia, seen in GATA2 deficiency, B, NK, and T cell deficiencies should also aware us to suspicion of inherited bone marrow failure syndrome. Unusual complication of chemotherapy or radiation, which necessitate therapy interruption. Or there is a family history of cytopenias, aplastic anemia, myelodysplastic syndrome, leukemia. There is a history of cancer in multiple relatives or cancer at young age or family members with multiple cancers. There are congenital malformations in family or familiar inheritance of pulmonary fibrosis or cirrhosis or lymphedema. These all should make us aware about possible bone marrow failure syndrome. So coming on to first bone marrow failure syndrome, which is inherited, Fanconi's anemia. Main clinical features are marrow failure. Initially, macrocytosis is seen, which gradually progresses to pancytopenia. There are many congenital anomalies, which we will be discussing in later slides. These congenital anomalies may not always be present, or it may be subtle, and they are not required for diagnosis of Fanconi's anemia. There is increased cancer predisposition seen in Fanconi's anemia, which can be AML or squamous cell carcinomas or mucosal surfaces. Brain tumors can also be seen. Also, Wilms tumor and other solid organ malignancies are seen. There is a history of familial malignancies in Fanconi's anemia. Various congenital anomalies which can be seen in Fanconi's anemia are most common are cafe au lait spots seen in the skin. This is a photograph depicting cafe au lait spots in the skin. Others can be short stature and upper limb or thumb anomalies, supernumerary or abnormalities in the thumb are characteristic of Fanconi's anemia. There can also be male or female genital abnormalities which lead to short stature. Some abnormalities can be seen in eye, renal, cardiac tissue, or GI or CNS. So diagnostic tests will be discussed by Dr. Sani Sharma ma'am.
For the diagnosis of a suspected case of Fanconi anemia, the most common test that is performed in the diagnostic hematology laboratories, so that is chromosomal breakage study. Since this is a DNA repair defect, so these patients, their cells, they are hypersensitive to certain cross-linking agents, DNA cross-linking agents or the clastogenic agents, which are not seen, which is not seen in a normal individual. So the cells of these patients, the peripheral blood mononuclear cells of these patients are harvested, and they are cultured and harvested in the presence of clastogen or a DNA cross-linking agent such as diepoxybutane or mitomycin C. And besides peripheral blood, even the skin fibroblasts can also be used and assessed in these suspected patients, especially when the peripheral blood counts are low or if the peripheral blood cells show normal results. So, so the typical picture, the microscopic picture is like this when we see these chromosomal metaphases. So in patients with Fanconi anemia, since there is a hypersensitivity of the cells or the DNA to these clastogenic agents, we will see these DNA breaks and gaps, like you can see over here, which are not seen when we have not added any clastogenic agent. But you will see these breaks and gaps and these rearrangements and these what is known as radials. So these, when we analyze the metaphases and we see such structures, such chromosomal abnormalities, we diagnose these patients as consistent with Fanconi anemia. And then we can further go for the genetic analysis by doing whole exome sequencing or targeted gene panels, and pinpoint the underlying genetic or the germline mutations.
Now coming on to the next inherited bone marrow failure syndrome, which is dyskeratosis congenita. It is an ectodermal dysplasia due to DNA repair defect. There is a characteristic classical triad of clinical symptoms, which are reticulated skin, hyperpigmentation, dystrophic nails, and mucous membrane leukoplakia. They develop in progression as per age. And we do not need the classical triad or physical stigmata of this disease for diagnosis. Aplastic anemia is seen in up to 50% of the patients in second or third decade. There is a higher risk of solid organ malignancies of head, neck, and GIT, and also hematological malignancy in form of leukemia in third to fourth decade. Most common leukemia seen is AML, and carcinomas of bronchus, tongue, larynx, esophagus, pancreas, and skin are also seen. This is the disease progression in time due to the mutation, different mutations seen, plus addition of environmental factors, which can be UV light or smoking or other infection. There is a premature telomere loss, which lead to increased chromosomal instability and premature death of mature cells, which lead to the clinical phenotype of this disease, which is composed of bone marrow failure and non-hematological malignancies like pulmonary disease and premature aging. And these all can lead to malignancies in later life. This is the photograph showing dystrophic nails, oral leukoplakia, and skin leukoplakia. This is the further image of this disease. Additional clinical features which can be seen are pulmonary disease, dental anomalies, esophageal stricture, hair loss and early graying of hair, GID disorders, ataxia, epiphora, hyperhidrosis, hypogonadism, microcephaly can also be seen. There is increased incidence of urethral strictures and phimosis. These all lead to osteoporosis, deafness, and cognitive and developmental delay. Different mutations in different genes are found in this disease. And now coming on to other rare inherited bone marrow failure syndromes under this IUIS classification. First is Mirage syndrome. It comprises of myelodysplasia, infection, restriction of growth, adrenal hypoplasia, genital phenotypes, and enteropathy. Gene involved is SAMD9. It is due to autosomal dominant gain of function mutation in SAMD9 gene. Additional associated features other than these classical Mirage syndrome features are IUGR, intrauterine growth retardation, gonadal abnormalities, adrenal failure, myelodysplastic syndrome. There is an increased incidence of chromosomal 7 aberrations seen in this defect. Enteropathy can also be seen. There is absent spleen and predisposition of infection. Other syndrome is ataxia pancytopenia syndrome. It is due to the SAMD9 ligand gene deficiency. It is also autosomal dominant gain of function mutation in this gene. The main features are neurological features, which are most commonly are ataxia, and myelodysplastic syndrome, which leads to pancytopenia. There is another syndrome known as bone marrow failure syndrome. It is of three types: BMFS1, 2, and 5. In BMFS1, the gene involved is SRP72. It is also autosomal dominant. It leads to bone marrow failure and congenital nerve deafness. In BMFS2, the gene involved is ERCC6L2. It is autosomal recessive, leading to bone marrow failure, learning difficulties, and microcephaly. BMS5 is due to deficiency in gene of TP53. It is an autosomal dominant in inheritance. It leads to erythroid hypoplasia, later converting on to bone marrow failure, and there is also B cell deficiency in this disease. Coats plus syndrome is due to deficiency or mutation in two genes, STN1 and CTC1. This disease is autosomal recessive. The clinical manifestations seen are intrauterine growth retardation, premature aging, pancytopenia, hypocellular marrow, GI hemorrhage, intracranial hemorrhage can also be seen due to severe thrombocytopenia, and there are abnormal telomeres. One syndrome is MECOM deficiency. It is autosomal dominant due to mutation in MECOM gene. The main features of this disease is bone marrow failure, which can lead to thrombocytopenia in later life. There is radioulnar synostosis, clinodactyly, and cardiac and renal manifestations are also seen. There is a syndrome called GATA2 deficiency. Although it is not classified under IUIS classification in inherited bone marrow failure syndromes, but this disease or GATA2 deficiency also leads to bone marrow failure. GATA2 deficiency presents with following four manifestations. Monomax syndrome due to deficiency in monocytes and some defects in macrophages. The other syndrome is dendritic cell, monocyte, and NK cell deficiency. It can also lead to lymphedema along with myelodysplastic syndrome. This syndrome is known as M-Burger syndrome. Pulmonary alveolar proteinosis can also be seen in GATA2 deficiency. And these all can later convert to myelodysplastic syndrome or acute myeloid leukemia. This GATA2 deficiency presents later in life than other bone marrow failure syndromes. It becomes symptomatic by the age of 20 years in the third decade. GATA2, this enzyme is critical for generation of hematopoietic stem cells. So in deficiency of GATA2, bone marrow failure occurs. Also, GATA2 binds to regulatory elements of genes which are required for development of vascular endothelial growth factor receptor. So in its deficiency, it leads to malformation of lymphatics leading to lymphedema. It can present with recurrent infections, which are most commonly due to non-tuberculous mycobacteria, HPV virus, EBV, CMV, herpes simplex virus. Fungal infections by Candida and Aspergillus can also be seen. The main immune manifestations seen in GATA2 deficiency are low B cells, low NK cells, and monocytes. T cells characteristically in this disease tend to be preserved longer, and ultimately later in life they reduce. Now, immunological abnormalities in inherited bone marrow failure syndrome will be discussed by Dr. Sania ma'am.
So thank you, Munish. So now I'll be discussing about the immunological changes that are seen in inherited bone marrow failure syndromes. And although these are, germline mutations which lead to different phenotypes and different, not only hematopoietic, but also the somatic and the different organ systems may be involved in these syndromes. But besides these heterogeneity and the phenotypic variability that is seen in these conditions, immunological evaluation and immunological changes have also been encountered, and probably that is why these syndromes, some of these syndromes have been classified in IUIS classification. So this is one of the papers from Italy, and it was published in '97 in Acta Hematologica. And in this paper, the authors, they have done the immunophenotyping of the patients with Fanconi's anemia and their family members. So what they found was that these patients who have Fanconi anemia and also their family members, they do have immunological abnormalities, not only in the patients, but also in their carriers, in the patients as well as their siblings. So they found certain immune aberrations, like the carriers as well as patients. They had reduced numbers of cells expressing CD25 and HLA antigens, although this defect was more pronounced in the patients who were homozygous for the mutation. And they had reduced total lymphocyte counts, they had reduced CD4 T cell counts, they had reduced B lymphocyte counts, and they had reduced CD4 CD8 ratio. So we can see over here that the patients with Fanconi anemia, so they had lowest absolute lymphocyte counts compared to the parents and the siblings, although siblings had higher counts, but both parents as well as the Fanconi anemia patients, they had lower absolute lymphocyte counts. And besides the lymphopenia, there was significantly reduced B cell counts in the Fanconi anemia patients as well as the parents. There was reduced CD20/3 ratio. There was reduced CD4 CD8 cell counts, CD4 CD8 ratio, and CD25 expression and the HLA antigens. So these were also reduced in both patients as well as the parents. And even these markers like 25 and HLA antigens were also reduced in the carrier siblings. Then another paper came up, and they also evaluated the immunological parameters in patients with Fanconi anemia. And they also said that the patients with Fanconi anemia, they do present with recurrent infections, especially the respiratory tract infections. And it is important to evaluate the immune profile of these patients, particularly the antibody-mediated immune responses. So in this study, they evaluated around 12 patients with Fanconi anemia between 5 to 32 years of age, and they did the immunoglobulin levels, isoheme agglutinin titers, IgG subclasses to various IgG antibodies to various antigens like polio, measles, and they also performed anti-pneumococcal antibody testing. So what they found was that out of 12, 10 patients had elevated IgE levels, and 7 patients had they had detectable specific IgE levels and positive immediate skin tests. And out of 12, 2 patients had abnormal response to the pneumococcal vaccine. And the isoheme agglutinin titers and the immunoglobulin profile and IgG subclasses were normal. Anti-poliovirus, anti-measles antibodies were within normal limits. And only 2 patients had IgG4 levels, they were undetectable. So they concluded that a proportion of patients with Fanconi anemia, they do have immune abnormalities in the form of inadequate response to the pneumococcal vaccine, although they did not find significant abnormalities, other immune cells in these patients. So this is the table showing the total IgE levels in these patients, which was elevated in 10 patients out of 12, and the 2 patients who had abnormal anti-pneumococcal vaccine antibody. So out of 6 serotypes, 3 serotypes were found to be reduced or abnormal in the post-vaccination phase in 2 patients. And this is the infection profile of these patients. They had features of upper respiratory tract infections like pharyngitis, tonsillitis, sinusitis, pneumonia, dental infections, stomatitis. So the patients with Fanconi anemia, they do have they do have recurrent infections. So this was another multi-centric study which was published in American Journal of Hematology, and they have also done the immune profiling of patients with Fanconi anemia. And in this, they have enrolled 61 patients with Fanconi anemia who had advanced bone marrow failure and who were planned for hematopoietic stem cell transplant. So in this patient, in this paper also, they found that the total absolute lymphocyte count, B cell and NK cell count was reduced when compared to the controls. In the T cell compartment, the cytotoxic T cells, naive T cells and regulatory T cells, they showed a relative increase when compared with controls. And they also found significantly lower levels of IgG and IgM, whereas IgA levels were higher in the patients than the normal controls. They also evaluated cytokines, and out of 10 cytokines, they found that TGF-beta and interleukin-6 were the 2 cytokines which were significantly elevated in the serum of patients when compared to controls, and soluble CD40 ligand levels were significantly reduced. So the authors suggested that a comprehensive immunological investigation in patients of Fanconi anemia with advanced marrow failure should be done, and these patients, they do have an altered immune status. which could be attributed to the pro-inflammatory and pro-apoptotic milieu of the bone marrow in these patients. So they found that the
కమోడ్స్ కూడా అన్ని చెక్ చేసిన పొద్దు నేను వచ్చి డౌట్ వచ్చి నేను అన్ని చెక్ చేసిన మళ్ళీ సార్ కూడా చూసిండు.
Yes, Dr. Shilekha, your mic is on. Kindly mute.
రేపు మాన్సా రేపు కొంచెం ఇల్లు దులపాల, ఫ్యాన్లు కిటికీలు. అయితే పొద్దున వేరే వాళ్ళు వస్తున్నారు ఇంటికి. సాయంత్రం నువ్వు వచ్చే టైంకే కొంచెం ముందు రామకృష్ణ వచ్చి చేసి వెళ్ళామాను, తర్వాత నువ్వు ఎట్లా ఊడుస్తావు. మీరు ఎప్పుడైనా రండి, ఆయన వచ్చి దులిపిపోతే తర్వాత నీకు ఈజీగా ఉంటుంది. ఊడ్చి చేస్తే అయిపోతుంది.
So these patients, they with advanced marrow failure, the absolute lymphocyte counts were reduced compared to the controls. B cells were significantly reduced, then controls, NK cells as well as the NK cells were also reduced, and the T cells, they were elevated than the controls. Then the cytotoxic T cells were significantly elevated, the naive T cells were significantly elevated, and the T regulatory cells were also significantly elevated in these patients. And then the immunoglobulin IgG levels were reduced significantly, so was IgM levels, and IgA levels were increased. And the cytokines, among cytokines, interleukin-6 and TGF-beta1 were significantly elevated, and soluble CD40 ligand levels were reduced. Then another study from Turkey, they also evaluated the immune system in patients with Fanconi anemia. And in this study, they found, they performed serum immunoglobulin levels and lymphocyte subset analysis in 25 patients with Fanconi anemia. And they found that out of 25, in only one patient, serum IgA and IgM levels were low. And lymphocyte subgroup analysis, which was done in 6 patients, revealed low NK cell counts in 2 patients. So they finally concluded that patients with children with Fanconi anemia have NK cell abnormalities, and these could be the leading cellular defects in these patients. So this was the lymphocyte count analysis, which revealed significantly reduced NK cells in 2 patients out of 6 patients. So similarly, there are other studies as well from different parts of the world which have shown that the immune system is impaired in children with Fanconi anemia. Like in this study, they have shown that in 10 children with Fanconi anemia, the absolute B cell and NK cell counts were reduced, and the absolute T cell counts were within normal limits. The functional activity of NK cells was also reduced. The NK cell cytotoxicity was reduced. Antigen proliferation in response to tetanus was decreased. And even the cytotoxic T cell function was reduced, although the counts were normal. IgG levels were normal. So different studies have come up with different results with respect to the immune abnormalities in these patients. And then this was another study. And in this study also, they have shown, the authors have shown that the patients with Fanconi anemia, they, in their cohort, they found that the NK cells, the CD56 dim as well as CD56 bright NK cells, so these subsets were altered, and these patients, they have an increased number of CD56 bright and CD16 positive NK cells, and they have a reduced proportion of CD8 positive T cells and CD56 dim and CD16 positive. So basically, the NK cells, the NK cell differentiation pathway is affected in these patients. Then another syndrome that has been classified in the IUIS classification, the major group of disorders, dyskeratosis congenita. So in this paper, the authors have described dyskeratosis congenita as a combined immunodeficiency with a broad clinical spectrum. And they have said that they have reviewed 7 patients with dyskeratosis congenita, and they have found different immune abnormalities like lymphopenia, low B cell numbers, hypogammaglobulinemia, and reduced T cell function, which were most frequent in these patients at initial presentation, and they preceded the development of the bone marrow failure in these patients like anemia and thrombocytopenia. And 6 patients, they had recurrent sinopulmonary and opportunistic infections that can very well fit into the inborn error of immunity. So, so you can see the infection profile in this table. So these patients, they had different different patients had different infection spectrum, ranging from PJP pneumonia in 1 patient to candida. Sinopulmonary infections was found in 3 patients, bacterial sepsis, and even the herpes viral infection was found in 2 patients. So again, these patients had reduced absolute lymphocyte counts. They had reduced, 2 patients had reduced T cell counts. 4 patients had reduced CD4 and CD8 T cell counts. CD4 CD8 ratio was also reversed in 3 patients. Then CD19 positive B cells were the most frequently the most frequent abnormality, CD19 B cell lymphopenia, and the NK cell counts were also reduced in 5 patients. And even the T cell proliferation was reduced in 6 out of 7 patients in response to candida as well as tetanus. And humoral immunity was also found to be reduced in the form of low IgG levels, low IgM levels, and low IgA levels, and decreased antibody titers to various vaccines. So in this paper, they have found that dyskeratosis congenita can also have T cell immunodeficiency. So there can be reduced lymphoproliferation in response to mitogens, and although the activation profile can remain normal. So another paper that found that the patients with dyskeratosis congenita, so they evaluated 10 members of a single 3-generation family for the autosomal dominant dyskeratosis congenita due to mutation in the telomerase RNA gene. And they found that because of these mutations, there can be B cell lymphopenia with decreased IgM levels, and even T cells can be involved. There can be increased T cell senescence, increased expression of CD57 and FAST receptor, which are the markers of T cell senescence. And T cells were also moderately reduced in these patients. So they concluded that the lymphopenia and the hypogammaglobulinemia in patients with autosomal dominant dyskeratosis congenita could be a consequence of the replicative failure and premature senescence of lymphocytes, again supporting a role of telomerase activity in immune homeostasis. And finally, this last slide of mine shows that this paper, this was a commentary in JCI, and in this commentary, the authors, they have shown, or they have reported that the interaction between NKG2DL, that is natural killer cell group 2 member D ligand. So interaction between this ligand with its receptor. So the ligand is expressed by the hematopoietic stem cells, and the receptors are expressed on the NK cells. So whenever there is any form of genotoxic stress, any form of environmental stress or genotoxic stress which leads to DNA strand cross-link formation. So normally it induces DNA damage repair and the activation of Fanconi anemia core complex. However, in patients who have Fanconi anemia associated gene mutations, so this DNA damage repair is interrupted, it becomes impaired, and therefore there is, in response to the genotoxic stress, there is increased expression of NKG2D ligand within hematopoietic cells, which go and bind with increased affinity with the NK cell NKG2D receptor. And due to this receptor ligand interaction, it leads to destruction of the hematopoietic stem cells and ultimately bone marrow failure. So therefore, it emphasizes the role of immune destruction, NK cell mediated destruction of the hematopoietic stem cells, which is causing bone marrow failure in these patients. Thank you.
Thank you, ma'am. So we have already discussed that bone marrow failure syndromes under IUIS classification are in table number 9. So according to clinical phenotype, they are classified into different categories. Fanconi's anemia phenotypically manifests along with CNS, skeletal, skin, cardiac, GI or urogenital anomalies. There are increased chromosomal breakages, pancytopenia is seen. Fanconi types are from A to W. Different genes are involved in different subtypes of Fanconi's anemia. All are autosomal recessive except FANC-B, which is X-linked. Dyskeratosis congenita phenotypically manifests along with myelodysplasia, and short telomeres are seen in it. We should exclude other causes like Fanconi's anemia or Diamond-Blackfan syndrome before labeling dyskeratosis congenita. Manifestations seen are IUGR, microcephaly, other skin changes, nail dystrophy, skin pigmentation, oral changes like leukoplakia. Different genes are involved in dyskeratosis congenita also. Bone marrow failure syndromes 1, 2, and 5 are also associated with the IUIS classification. Other syndromes like Mirage syndrome, ataxia, pancytopenia syndrome due to SAMD9 ligand autosomal gain of function mutation. There is syndrome called Coats plus syndrome due to 2 mutations, either in STN1 gene or CTC1 gene. Osteopetrosis under this classification is also a form of bone marrow failure, and MECOM deficiency causing thrombocytopenia, pancytopenia, and clinodactyly, cardiac and renal manifestations are also classified under bone marrow failure syndromes. So we'll discuss an interesting case. A 10-year-old boy, this is the index child or patient 1 which came to our hospital for management. He was born to a non-consanguineously married couple. There was a history of prolonged fever, generalized swellings over body, easy fatigability, although there was no history of bony pains. On examination, he had pallor, generalized lymphadenopathy, and firm hepatosplenomegaly. There was a strong family history of illness in the family. His first sibling was asymptomatic, although on examination, he had a firm splenomegaly. Second sibling had a history of severe anemia, which was transfusion dependent, and he was diagnosed as a case of pure red cell aplasia. We did the investigations in the index child who came to us. He was showing anemia. Total leukocyte counts were also less, 0.6, with the neutrophils of only 9%. Platelets were 5,000. So he was showing pancytopenia. Immunoglobulin profile revealed low IgG, IgA, and IgM. He had hypogammaglobulinemia. His B cells were low, 1.2% only, although T cells and NK cells were normal. So this patient had pancytopenia with hypogammaglobulinemia with low B cells. The siblings of the index case also they didn't have the main classical features of pancytopenia, but bone marrow biopsy done in the one patient showed erythroblastopenia, which is a diagnostic of pure red cell aplasia. Genetic evaluation done for the patient showed a compound heterozygous mutation in exon 5 of ADA2 gene. There were two mutations found. First was a nonsense mutation, and second was a frameshift mutation. So this compound heterozygous mutation led to a diagnosis of ADA2 deficiency, or what we called deficiency of adenosine D-2. The genetics done in the other two siblings also showed same compound heterozygous mutation as the index child. Father was a heterozygous carrier of a first mutation which was seen, this frameshift mutation. Father was a carrier of this mutation, while mother, we couldn't do the genetics in the mother, but we expect her to be carrier of the second mutation. So in all of the three children, the same gene was involved, showing compound heterozygous mutation in the same ADA2 gene. But all the three had three different manifestations. The first child presented with pancytopenia along with hypogammaglobulinemia. Second child was asymptomatic but only had splenomegaly. The third child presented with pure red cell aplasia. So this gene, ADA2 gene, lead to deficiency of adenosine D-2, what we usually call DADA2. It is an autosomal recessive disease caused by loss of function mutation in the ADA2 gene. It was previously labeled as CECR1 gene. The first description of this disease came in 2014, and it is the latest or newly diagnosed disease. ADA or adenosine D-, it regulates the purine metabolism by facilitating the conversion of adenosine and 20-deoxyadenosine to inosine and 20-deoxyinosine respectively. There are two forms of adenosine D- enzyme. ADA1 we had studied earlier. It was associated with severe combined immunodeficiency, while ADA2 gene, it is associated with this disease. It is mainly produced and secreted by myeloid cells, such as activated monocytes, macrophages, and dendritic cells. The deficiency of ADA2 or ADA1, absence of one enzyme is not compensated by the other enzyme. There are three mechanisms by which ADA2 leads to this disease. A deficiency of ADA2 leads to polarization of macrophages. This is the flow chart which will explain the disease better. This ADA2 deficiency leads to macrophage polarization. There is more of M1 macrophages and low M2 macrophages. It also dysregulates the netosis. Neutrophil extracellular traps is dysregulated due to ADA2 deficiency. Altered endothelial cell integrity is there in ADA2 deficiency. B cells, mature B cells are decreased. So in B cell, in this ADA2 deficiency, hypogammaglobulinemia is seen. It can present with different manifestations. It can present with bone marrow failure, initially presenting with pure red cell aplasia, and later on it culminates towards bone marrow failure. Vasculitis can be seen, which can lead to stroke-like episodes. This is a paper which published by our institute, which showed the deficiency of adenosine D- type 2. It is a diagnostic conundrum for the hematologist because it can present with different manifestations. This is a normal marrow with a normal ADA2 enzyme. While in ADA2 deficiency, M1 macrophages are more as compared to M2 macrophages, leading to low B cell, mature B cell. There is impaired class switching, decreased IgG, decreased B cells and decreased NK cells. There is overall lymphopenia. leading to different manifestations of this disease. When should we suspect this deficiency? If early onset presentation like PAN or polyarteritis nodosa is there, early onset presentation, we should suspect DADA2 deficiency. There are recurrent episodes of stroke associated with immunodeficiency syndromes, pancytopenias are there, or familial pan is there. Then we should suspect DADA2 deficiency. Next topic, phenocopies of inborn errors of immunity will be discussed by Dr. Rakesh, sir.
Thank you, Dr. Munish. So, till now, we have discussed 9 classes of the inbornness of immunity, and we were talking about the underlying genetic diagnosis. So many a time we will not be able to get an underlying genetic diagnosis, and some type and proportion of patients who has suspected to have inborn errors of immunity, but still we are not able to find out the underlying genetic cause despite the extensive immunological investigation and despite the genetic diagnosis of. So whether we are dealing with these types of inborn errors of immunity. So phenocopies are defined as a clinical non-inherited phenotype. So these are non-inherited. First is in an individual with environmental induction which is identical to the genetically determined phenotype of another. So in a simple sense, there looks like underlying genetic inbornness of immunity, but we are not able to identify the underlying genetic defects, and these can be due to the two major factors which has been identified recently is one are autoantibody productions and second is somatic mutation. So we all know that once that age in even after age increment that there are increased somatic mutations, and some of the somatic mutation can create problems in adulthood or older age. So the somatic variants should be considered in a patients with clinical diagnosis of IEI in absence of a family history where broad genetic testing has not been revealing. So we have done all the genetic investigations, but we are suspecting a underlying inborn error of immunity or underlying inborn errors of immune defects, but we are not able to find out the genetic diagnosis. Then possibly we may have underlying, and that can be due to the somatic variants or it can be due to the autoantibodies. So broadly we can divide them under the somatic mutations or autoantibodies. So somatic mutation can be find in the TNF RSF6 which is related to the ALPS like phenotype, or it can be due to the RAS associated autoinflammatory disease, that NRAS and KRAS mutations, or it can be due to the autoinflammatory syndrome like NOMID like presentation due to the NLRP3 somatic mutation. So we all know that NOMID or SINCA or this can be due to the underlying monogenic defect, but several patients with NLRP3 associated inflammatory may not have underlying monogenic cause and somatic mutation may be there, and the STAT5B gain of function can also be due to the somatic mutations. Other autoantibodies which has been identified and leading to the severe infections are like autoantibody against the IL-17, IL-22, IL-6, interferon gamma, GM-CSF, or C1 inhibitors and factor H. So we'll know all this in the coming slides. So the first part is that autoantibody phenocopy is associated with somatic mutations. So somatic mutations are the phenotypes which can be found out in these immunodeficiencies are ALPS-like phenotype, like autoimmune lymphoproliferative syndrome. So we all know that ALPS can have underlying monogenic defects, but several patients with ALPS, we may not able to find out the underlying genetic defects, and in these patients we can have somatic mutations, and we have to investigate. So after the investigation of monogenic single nucleotide monogenic variants, if they are not available in ALPS patients, we have to investigate for them for somatic mutations, and these patients can typically present like similar phenotype like splenomegaly, lymphadenopathy, autoimmune cytopenias, and defective lymphocyte apoptosis. So the presentation is similar, but we are not having a germline defect basically. So the defect is more of somatic. Other defects which are RAS-associated autoimmune leukoproliferative disease, which can be due to the somatic mutation in KRAS or somatic mutation in NRAS. These are gain of function mutations, and these patients also presents like ALPS-like presentations, and they can have a combined immunodeficiency like presentation. So, and typically these patients can have JMML like, so juvenile monomyelocytic leukemia like presentation in early childhood. And so whenever we are having JMML like illness, and if there are these somatic variants can be responsible for that. As I was highlighting regarding the cryopyrinopathies like Muckle-Well, Senka, Nomad-like syndromes, and you almost 60 to 70% patients with cryopyrinopathies can have somatic mutations, and we may not be able to find out the germline mutation. So whenever we are not having germline mutations, we should not rule out the diagnosis of cryopyrinopathies. And several patients, like big proportion of patients, can have somatic mutation in NLRP3 genes, and that they can present like typically like same presentations. Hypereosinophilic syndrome due to the somatic mutation in STAT5B can present as eosinophilia, atopic dermatitis, or arterial rise and chronic diarrhea. The VAXS syndrome, that the acronym stands for vacuoles, even enzyme, X-linked autoinflammatory and stomatic syndrome. So which is usually present in adulthood or maybe elderly people. So these are very late onset treatment refractory inflammatory symptoms. They present with like severe chondritis, severe vasculitis, interstitial nephritis, and they can have bone marrow dysplastic bone marrow also. And the last, which is has been recently identified in 21 only, so TLR8 gain of functions, so which can have, and the somatic mutation in TLR8 gene can be associated with bone marrow failure like presentation with significant neutropenia and recurrent infections, and these patients can have significant hyperinflammation. So second part of phenocopies was those who have associated with autoantibodies. So these patients are usually have severe infections. So the patients they can have severe infections, and these phenocopies have usually described in adults and adolescents, and not in children yet. So most of the time, whenever we are having a severe infection in adults, we should suspect inborn immunity, and if we are not having underlying germline mutation has not been identified, so maybe we are dealing with the autoantibodies. So chronic mucocutaneous candidiasis, which we all know CMCCs can have associate, and we all know that IL-17 or IL-17 pathway is involved for the eradication of the fungus. So if there is autoantibody to IL-17 or IL-22, they can present with chronic mucocutaneous candidiasis. And patients with autoimmune polyendocrinopathy, that is APCD, can have associated autoantibody to IL-17s, and that can also lead to the increased infections of fungal infections. Another is, we all know about the Mendelian susceptibility to mycobacterial disease, MSMD, so which is typically present in children with susceptibility to the intracellular organisms like mycobacteria, fungal, viral, and whenever they present the typical recurrent infections of mycobacterium like non-tubercular mycobacteria or other environmental mycobacteria or PCG type infection in adults or severe viral infections, maybe the underlying defect may not be a germline mutation in these patients during the adulthood, and they can have adult onset immunodeficiency with susceptibility to mycobacteria due to the autoantibody to the interferon gamma. So typically these patients with severe infections also have concomitant autoimmunities also because of these autoantibodies. They due to the autoantibody against IL-6 can lead to the increased propensity to development of staphylococcal infections, and recurrent skin infections can be found in these patients. We all know about pulmonary alveolar proteinosis and cryptococcal meningitis and disseminated nocardiosis. So we have seen these patients in adult, and probably we have to suspect that why these patients are developing these funny infections or pulmonary alveolar proteinosis, whether it is just an incidental or whether we are having underlying cause. So if there are no underlying germline mutations, so probably it can be due to the autoantibody to the GM-CSF. So autoantibody to GM-CSF can lead to the pulmonary alveolar proteinosis, cryptococcal meningitis, or disseminated nocardiasis. Hereditary angioedema, we all know about that. It is due to the defect in underlying germline mutation in the C1 inhibitor gene, but if there is a autoantibody against C1 inhibitor, which is usually present in adulthood, so whenever the angioedema is presenting late adulthood, and if we are not having underlying germline mutation, so probably we are dealing with acquired angioedema, and this is more common associated whenever we are having associated autoimmune disease like this. These patients can have underlying autoimmune or connective tissue disease disorder, like they are more of common with associated with lupus or rheumatoid arthritis. Atypical HUS, we all know that it is due to the defect. It can be due to the germline mutation in complement effect, due to the complement factor H deficiency due to the germline mutation, or it can be due to the autoantibody to the complement factor H. And this is a so we all know that these patients require an aggressive treatment with immunosuppression. The good syndrome, which all know that thymoma with hypogammaglobulinemia, and which can be due to the autoantibody to the various cytokines, and which has not been identified as a which cytokines are responsible for the and we have seen that during the severe COVID-19, significant number of patients, or maybe few patients who have developed severe hyperinflammation, and during the adulthood, whether the severe life-threatening infection with SARS-CoV-2 was due to the basically incidental, or it was due to the underlying genetic or underlying autoantibodies. So autoantibodies to type 1 interferon has been identified in patients who have severe life-threatening infection with SARS-CoV-2. So just to summarize that, whenever we are having these autoantibodies, pre-existing anti-cytokines or interleukin autoantibodies, the anti-pathogen response to host is not as it should be in an immune competent persons, and these patients can present like MSMD or like a chronic mucocutaneous candidiasis, pulmonary alveolar proteinosis, or can we have severe COVID-19 disease. So both pathogen clearance is also defective, and also there is a significant inflammation and tissue damage leading to the autoimmunity and also infection. So these patients with autoantibody along with antimicrobial will require immune modulations also. Why it is important to identify autoantibodies is because that will change the treatment, how we have to treat these patients. And there are several hypotheses for development of cytokine autoantibody productions, and these are in nascent phase, but still they say that because of aberrant negative selections or abnormal germinal center reactions, or it can be due to the molecular mimicries leading to the autoantibody production. So these autoantibodies are broad, and they broadly produced by and induced by the specific pathogen. So these patients have restricted infection to specific pathogens, and the defect is not germline, but it is due to the pre-existing anti-cytokines or anti-interleukin autoantibodies, and leading to the defective pathogen clearance. So again, just to summarize that, whenever we are having viruses effectively cleared by the type 1 interferon response. So if there is an antibody against the type 1 interferon, then these patients can have severe viral infection like varicella zoster, or it can have other viral infections. So bacteria are usually, the response is Th1 cell dependent, or interferon gamma or IL-6 mediated. So if there are autoantibody against IL-6 or interferon gamma, then these patients can have severe bacterial infections. And fungi are cleared by the Th17 pathways, and if there are autoantibodies against Th17 related autoantibodies, these patients can present like CMCC like presentation. So, which I was highlighting that severe COVID-19 represents an undiagnosed primary immunodeficiency in high proportion of infected individuals, and when the authors have shown that the group of relatively younger COVID-19 patients who underwent whole genome sequencing are subsequently assessed for the presence of autoantibody to type 1 interferons. And the 10% of severe COVID-19 patients were found to have autoantibodies against type 1 interferons versus none of those with minimal disease. So the severe COVID-19 is also associated with significant finding in the neutralizing type 1 interferon cytokines. So as I was highlighting that acquired angioedema is due to the autoantibody to the C1 esterase inhibitor. So we have seen that most of the autoantibodies to cytokines or interleukins has been seen in the adulthood or elderly population, but whenever we are not having in recently it has been identified in the pediatric population also. So juvenile onset immunodeficiency secondary to the anti-interferon gamma autoantibodies, which is also they have given the acronym of ISIGA syndrome. So although previously not reported, but whenever we are not having very serious infection to do the unusual organisms and we are not able to identify the underlying genetic and germline defects, possibly we have to investigate them for anti cytokines antibodies. So in this case the patient had a recurrent or disseminated NTM infections, and the finally anti-interferon gamma autoantibody was identified when they have not able to identify underlying germline defect. The clinical manifestations of these patients are indistinguishable from those presented by inborn errors of immunity. So that defect you can only diagnose or you can only suspect phenocopies when you are not having underlying germline mutations. Or we have to identify these patients because the treatment is different, and these patients are at predisposition to develop the severe infections and during our recurrent infection during the life course. So this is a flow diagram which suggests that whenever we are dealing when we are suspecting the clinical immunological suspicion of inborn nerve immunity, and if we are able to rule out the underlying genetic defects, and if still feel that it's a basically inborn nerve immunity, then basically we have to think for the somatic variants or maybe due to the autoantibodies against cytokines. So just to summarize, phenocopies of PIDs can be associated with somatic mutations or associated with autoantibodies. So those are associated with somatic mutations are ALPS or rasopathies or cryopyranopathies or hypereosinophilic syndrome due to the somatic mutation in STAT5B, or it can be the Vexus syndrome, which is very late onset and can be associated with significant severe inflammations, and these patients have polychondritis or severe polychondritis or severe interstitial nephritis. And then last one is TLR gain of function, which can be presented with hepatosplenomegaly, bone marrow failure, or severe cytopenias. Whenever they are associated with autoantibodies like CMCC, adult onset immunodeficiency with susceptibility to mycobacteria, recurrent skin infection, pulmonary alveolar proteinosis, acquired angioedema, atypical HUS, thymoma with hypogamma, and severe COVID-19. So whenever we are having severe infections, we have to think that whether we are dealing with phenocopies or PIDs. Thank you. So if there are any questions, we will see.
So any questions or any comments?
Please unmute yourself and you can ask questions now. So there is one question in the chat box: how to prove somatic mutations but not germline mutation?
Yeah, so for germline mutations, basically when we do this, testing on NGS. So suppose if you have a mutation which is, the variant allele frequency is very low. For example, the coverage is good, but the frequency of that mutation or that variant is coming out to be low, like 5%, 10%. So probably that could be your, somatic mutation. And to prove that, you have to, you can go for testing in the fibroblasts. So if it is not there in the fibroblasts, so it is a somatic mutation. It's not a germline mutation. And then there are different, NGS platforms, and they have different pipelines. Suppose if the germline filters or pipelines, they are not showing any germline mutation, then you can go ahead and do the, you can request for somatic mutation analysis pipelines.
Any other comments or question?
So one question is about what we should test autoantibodies like 5 or 10-year old. So this is very important question. Basically, till now the autoantibodies have been identified in adulthood, not in children. Basically, so children's there are only 1 or 2 case reports. So possibly I will not be able to tell the at what age, but whenever it occurs in adulthood, we should investigate for the autoantibodies if we are not having underlying germline defects. But the data in children is not very robust, and people have not investigated till now. But when it's well proven in adulthood that whenever we are having severe recurrent infections with restricted type of infections, like whether it is NTM or whether type of severe viral infections, or maybe recurrent staph infection in adulthood or young adults, then we should suspect that whether we are dealing with phenocopies due to the autoantibodies. So, but in children, the data is not very robust, and probably we have to rule out first germline defect very extensively, and then if still there is no underlying genetic defects, we may suspect, but we don't know whether we have significant number of autoantibodies in children also.
Thank you, sir. There is another question. In a patient with disseminated tuberculosis, she has hepatosplenomegaly and comes with recurrent warm autoimmune hemolytic anemia. Should we suspect ALPS? What is the clinical approach to diagnosis of ALPS?
So this patient has disseminated TB. So disseminated TB with autoimmunity, basically, what I can look. So there can be several causes, and it depends on at what age a child presenting. So disseminated TB with autoimmunity can be presentation of any combined immune defects. It can be a presentation of Mendelian susceptibility to mycobacterial disease, and it can also be ALPS. But usually ALPS patients will not have a disseminated TB as a presentation. So whether it is and TB came late only. So on the basis of just disseminated TB, hepatosplenomegaly, and recurrent warm autoimmune hemolytic anemia, we cannot say that just we have to investigate for ALPS. We have to suspect, and we have to investigate basically several immunodeficiencies, and based on the initial phenotype or initial blood investigation and further immunological investigation, we will be going for ALPS. For autoimmune lymphoproliferative syndromes, again, it is a hypergammaglobulinemia with autoimmune lymphoproliferations, and there is a significant. It can be autoimmunity associated, and there are several other surrogate markers like vitamin B12 can be significantly elevated, and then we can have flow cytometry for the fast ligand expression, and finally we can have next generation sequencing or targeted gene panel for the ALPS like phenotype. But significant number of ALPS patients can have somatic variants. So even if after if that which I missed is double negative T cells. So double negative T cells, which if these double negative T cells are more than 10%, then probably we are dealing with ALPS like illness. So but ALPS or ALPS like illnesses. So ALPS is a one diagnosis, but several illnesses which can present like ALPS like illnesses can have underlying, can be due to that underlying combined immune deficiency, or it can be due to the monogenic CVIDs like PI3 delta kinase. APDS or activated PI3 delta kinase can also present like this disseminated TP, hepatosplenomegaly, and autoimmunity. So one has to see in a broader perspective, and probably in presence of infections, one may have to rule out other immune defects also.
Thank you, sir. If there are any more questions, you can unmute yourself and ask, or you can even type in the chat box. Sir, ADA2 deficiency should work up for interferon 1, type 1 interferons? Possibly, the question is, in ADA2 deficiency, should we work up for type 1 interferons? Maybe type 1 interferonopathy. Is that what you mean?
I think if there is AD2 deficiency can have increased type 1 interferon signature, but usually the phenotype is because of increased type 1 TNF alpha increment and M2 macrophages skewing. So I'm not sure whether we have to measure the type 1 interferon, because that it may not affect the treatment, or I have not get your question directly whether, but yeah.
Hassan, you can actually unmute yourself and ask your question directly. Okay. So to keep the discussion ongoing, so there is one question. In what form of tuberculosis do we have to work up for anti-interferon gamma antibody in adults? And what is the role of IGRA in diagnosis?
So whenever we are having TB due to the NTM or environmental mycobacteria, or due to the infections which are not commonly, so we will not investigate for mycobacterium tuberculosis as an autoantibody to interferon gamma. But whenever it is NTM, non-tubercular mycobacteria, or other environmental mycobacteria are isolated, then we have to investigate for those patients for phenocopies, if we have ruled out the germline mutations. So again, it's not that the MSMD cannot present in later age. Mendelian susceptibility to microbacterial disease can present in later age. So based on the initial investigations, if the germline defects are not there, probably we have to investigate these patients, specifically when they are having atypical mycobacteria or non-tubercular mycobacteria or other environmental mycobacteria which are not typically seen in the patients. The role of IGRA is specifically, I think it's more of it's can just give a clue regarding the whether we are dealing with autoantibodies to type 1 interferon gamma. So IGRA may not show the same response, and but MEN2 can be positive in these patients. So that will give just a surrogate marker. But again, to prove that we have to go for autoantibodies, and these autoantibodies are not simple to measure, and these these assessment measures are not available, I think, commercially till now.
Thank you, sir. Are there any more questions?
I think if there are no more questions, we can conclude the session. Dr. Pallavi?
Yes, sir. There are no more questions in the chat box. If anyone has any question, last moment questions or anything, please ask either directly or chat or in the chat box.
So, in meanwhile, if there are questions, you can think over. And the last session, which is for the quiz, so which will be interesting session, and which would depend on that how sincerely or how like diligently you have attended all the sessions, and we'll check your knowledge, and that quiz will also help in our update in our knowledge also, and that quiz would be on 18th of November. So we will not be having session on 11th of this 11th November, because that comes like near Diwali, and we don't want to spoil your Diwali for that quiz, and that will be on 18th of November, and we would inform by mail also.
So regarding your question on ADA2 deficiency, should we work up for type 1 interferon? So I guess right now there are no guidelines or any, diagnostic criteria that have incorporated type 1 interferon in the lab diagnostic workup of these patients. Type 1 interferon signature, the interferon stimulated gene. So they have been found to be increased in these patients. And it is primarily, being evaluated on a research basis. Although for the diagnosis in a patient with suspected ADA2 deficiency, currently we go for the serum ADA2 levels, or we can go for the genetic sequencing, and TNF alpha cytokine levels you can measure, but if you want to do it on a research basis, currently it doesn't have any therapeutic implication except for TNF alpha, against which you have this drug, that is adalimumab and infliximab.
So one of the question is, are there recordings of the session? So we are really sorry that we don't have a recording for the session. So these are the real lifetime sessions, and we don't have recordings for these sessions.
But we will try to from next year. This was our first attempt. Next year we'll be rewinding these sessions, or we'll have new sessions on PID, and we'll try to record those sessions and mail you as soon as the session is over. So this time we don't have any recordings.
Okay, thank you for participation.
Shall we conclude?
Yes, sir. Oh, there are no more questions. Thank you everyone for the active participation. Thank you all the speakers, and we wish you all a very happy Diwali. And we'll meet you in the next session, that is on the quiz, that is on 18th of November. All the very best for all of you. Thank you. Have a good day.